Hello and welcome to Triage, timely conversations for healthcare professionals, a podcast created and produced by K&L Gates. Each episode is designed to highlight important developments in health law and analyze the impact on our clients and friends of the firm. We hope you enjoy this podcast.
Hello, this is Stephen Bittinger, and I'm a partner with K&L Gates Healthcare Practice Group. My practice focuses on reimbursement and audit and integrity work. Today for Triage, I am joined by my partner, Nate Huff. Nate, would you introduce yourself?
Hi, I'm Nate Huff, a member of the K&L Gates Healthcare Fraud Task Force. My practice focuses on white-collar defense and complex commercial litigation. It's great to be with you, Stephen.
Hey, thank you. And for this episode of K&L Gates Triage Podcast, we'll be looking at enforcement developments in the Medicare Part C or Medicare Advantage space. We're going to be looking at its growth and specific elements of MA and the reimbursement processes that factor into False Claims Act liability, both for Medicare Advantage Organizations, MAOs, and for providers. We're going to look at some of the recent publicity with public letters regarding a call for an FCA task force specifically focused on MAO fraud. And finally, we're going to close out with some key takeaways for both MAOs and provider perspectives. So just on a few intro notes, why is this becoming such a hot issue? Well, predominantly because a lot more money is becoming involved. For example, since in 2003, only about 13% of Medicare enrollees chose Part C plans. But in 2021, more than 26 million Medicare beneficiaries, or 42% of all beneficiaries, were enrolled in a Part C plan, which made up, according to the Congressional Budget Office, payments of about $343 billion to private carriers to administer these plans. The CBO also estimates that about 51%, or $600 billion, will go into MA plans by 2030. Just real quick nuts and bolts, if you're first time in the Medicare Advantage arena, the Medicare Advantage space is basically the mechanics, unlike traditional fee-for-service, where a capitated payment is made to an insurer who is administering Medicare's beneficiary payments based off of risk scores. And the amount of those capitated payments is adjusted based off of the diagnoses codes and procedures that go into a risk score for each beneficiary and to determine how much they are anticipated to need services. And this risk adjustment reimbursement process is integral to FCA's and allegations of asserting MA fraud. So, Nate, what are some of the interesting developments on the public side coming out of DOJ?
Well, the one that's on the front of my mind is the increased emphasis on enforcement and investigations. As the popularity of the program increases and enrollments increase, and there's increasing hundreds of billions of dollars being paid out, you would expect that DOJ would take an increased interest in fraud in this area, and certainly they have, and they've been making several statements to that effect over the last couple of years at ABA conferences, Federal Bar Association conferences, etc.
So recently, the American Hospital Association sent a letter to the DOJ calling for an FCA task force to investigate commercial health insurance companies operating as MAOs that are found to routinely deny patients access to services and deny payments to healthcare providers. Can you provide a little bit of color as to what precipitated this call for enforcement?
In early May of this year, HHS OIG published a report where it outlined concerns with the type of denials you just described, Stephen. So essentially, they're concerned that patients or enrollees in the Medicare Advantage program who were submitting prior authorization requests were having those denied, even though they would and should have met the criteria under normal Medicare Part A and Part B, and thus were being denied access to medically necessary treatment similar denials were being made with regard to requests by providers for payment. And so this report issues in early May, and the letter you're talking about from AHA came out in response to that. And AHA described the problem in some detail, and they basically described how the denials happen. They said, look, these Medicare Advantage organizations are wrongfully denying these requests because they add additional criteria that are in excess of what is allowed by Medicare, and that results in these denials. And they request unnecessary documentation from the enrollees, and that results in these improper denials. And there's errors in the way that they're reviewing these requests for payment and these requests for prior authorization, and that results in denials. And so they conclude that the report from OIG didn't go far enough. And so they start calling for a False Claims Act task force where they hope to see some of these Medicare Advantage organizations actually get prosecuted.
But am I correct in thinking that this is not a new liability source for MAOs? Haven't there been some recent cases against MAOs in the FCA arena?
Absolutely. I think going back the last few years, we've started to see and have been seeing, settlements in the hundreds of millions of dollars sometimes in cases like these, and statements and press releases from the Department of Justice, publicizing those outcomes, and a couple of them in particular I think are worth mentioning. The first one is from the Western District of New York. It's the Independent Health case. That's from 2021, and essentially what the department is alleging there is that Independent Health, through a subsidiary, was doing chart reviews. And by doing these chart reviews, what they were doing was looking to add diagnosis codes after the fact that would make the patients look sicker than they were, so that they would have a risk adjustment in terms of the reimbursement they could get. So in other words, they're going to add these codes to make the patients look sicker so that they can get a higher reimbursement. And the way that they were doing that, according to DOJ, was they were including codes that were not supported by the medical records, and they were adding these codes far after the fact, so not close in time to when the treatment happened. And then to substantiate the codes, they were asking the providers to sign addenda that would get submitted, and that were allegedly false or encouraging the provider to go along with a code that maybe wasn't entirely accurate. Again, all with the alleged goal of being able to get an upward risk adjustment so that they could collect more revenue on a given enrollee or across hundreds of thousands of enrollees. There was another similar case I think that's worth mentioning, this one from the Northern District of California. Again, it included the same issues. It was going back and auditing these records to try to add diagnosis codes so that the MAO could receive higher reimbursement. And again, that case, I believe, is still pending, and I think the alleged damages there are in the billions of dollars.
And that's the Kaiser case, right?
That's the Kaiser case. Thank you. So both of these cases kind of start to show, they're both good examples of the ways that MAOs start to increase their exposure to False Claims Act liability.
So what can you tell these cases about the sources or theories of liabilities against MAOs?
Yeah, so it's False Claims Act liability is the headline one, right? So essentially, when you're doing a chart review, which is a fine and acceptable thing to do, as I know you know, you can start to incur False Claims Act liability if you're adding codes that are not supported by the medical records, or you're doing it not close in time. And then, you're susceptible to DOJ saying, well, those codes are false statements as part of a claim for payment. And a similar thing is true as part of your chart review. You're using those addenda. The liability theory there is, well, this addenda is a false record in support of a claim for payment. And then finally, these MAOs were getting themselves into trouble because when they did their audits, if they saw codes that were mistakenly added, they stayed quiet and turned a blind eye but yet they were at the same time adding new codes. And so in that case, there's a theory of liability that they were knowingly retaining overpayments in violation of the False Claims Act. So the headline is these cases are good examples of ways that these MAOs were taking on False Claims Act liability. And I think an interesting aspect of these cases that maybe you could talk to is these problems and these concerns are not just for the Medicare Advantage organizations, but they could also affect providers, correct?
Yeah, you're right, Nate. So, I think Sutter Health is probably the strongest recent example there. In 2021, Sutter Health, along with several of their medical practice foundation affiliates, agreed to a $90 million settlement to resolve an FCA allegation of submitting inaccurate information about the health status of beneficiaries within Sutter Health's own MA plan. It was the largest settlement ever paid by a healthcare provider based on allegations of MA fraud. And really what the government focused on was normal tasks like tracking risk adjustment data, educating training physicians on diagnosis coding, scheduling annual wellness exams, and doing those in improper ways, right? It's all intent-based in FCA analysis. And there are, the government really focused on the plan that Sutter had put together was not intended to be accurate, but intended specifically to create greater revenue than they were entitled to. But I do think the thing that probably hit home the most and caused the resolution was that Sutter Health had become aware of the unsupported diagnosis codes and failed to take sufficient corrective action to identify and delete those, and thus ended up holding an improper overpayment according to the government. Sutter Health also agreed to a corporate integrity agreement that they have to live with based off of that case. But it's interesting, not all of the theories of liability in the MA arena are as straightforward as a submission of improper codes. The UPMC case, that's the University of Pittsburgh Medical Center that came out last year, is a rather more unique theory of liability, where the government there alleges that non-compliant surgical procedures which cause complications, lengthy hospital stays, and or more complex follow-up procedures were intentional, and that resulted in diagnosis codes that increased risk scores and heightened the capitated payment. Essentially, the DOJ appears to be trying to assert FCA liability based off of, poor MA patient outcomes and non-compliant surgeries. Now, that one's still pending in the Western District of Pennsylvania. We'll have to see how that one plays out.
It sounds like, if I'm understanding you correctly, Stephen, that there's some overlap in the theories of liability that I was describing with regard to MAOs and to the cases you're describing here involving providers. Is that right?
Yeah, absolutely. And, I think the most, when you boil it all down, whether it is intentionally submission of improper information to receive higher payment or intentional conduct that is to reduce cost, you're talking about holding funds that you're not entitled to. And that's reverse False Claims Act liability. And I know there's a hot debate raging on the provider side, but it's pretty clear on the payer side where the courts are falling. And the DOJ, because there's such enormous amount of government funds involved, is clearly willing to be aggressive and put their weight and strength behind some, even a little more tenuous theories on liability. So Nate, as far as takeaways, what are the key things for MAOs to know?
Well, first, fraud in Medicare Advantage is a growing priority for the Department of Justice. And they're looking at ways that MAOs, they're looking at things they do to cut their costs so that they can keep more of the capitated reimbursement, right? One way to do that could be to fraudulently deny prior authorization requests or payment to providers. So the DOJ is looking at that, and we've started to see activity in that area. And then, of course, there's already a line of cases with large settlements or large demands pending involving the revenue side, where MAOs are doing things to try to increase their revenue by making their patients appear more risky or more sick so they can get an upward risk adjustment and get more revenue there. So those practices under both are being scrutinized. And so I think that MAOs need to make sure that their coding practices are tight and supported by proper documents when they're doing chart reviews, which are a regular part of practice. They want to make sure that they're, again, supporting any of the codes that they're using, that they're not turning a blind eye to any improperly submitted codes that they find, and that if they're using addenda, those addenda are accurate and are not suggestive of certain codes. I think those are some of the key takeaways for MAOs in this environment.
Yeah, and on the provider side, it really boils down to 4 main points, which is DOJ intervention, proper documentation, paying attention to audits, and implementation of compliance plans. So on the DOJ intervention, I think the Sutter and the UPMC case make it very clear that the DOJ is willing to be aggressive, and they are going to be examining the mechanics of how providers, whether they own the plan or they're involved as a participant in a plan, how are they participating in these new mechanics. On proper documentation, listen, diligent documentation practices are critical for both MAOs and providers because you need to diligently monitor and verify, right? Verification of clinical documentation is probably the most important aspect of risk adjustments, right? You cannot overreach. And then as Sutter Health clearly demonstrates, paying attention to audits, right? You know, I'm an audit and integrity lawyer, so I know that providers sometimes they hear risks all the time, but you've got to pay attention to audit results and make sure that you are going to react correctly and deal with it and implement corrective action. And finally, you know, the cardinal rule for operating as a provider in healthcare is do you have a good compliance plan, right? Do you have a record of, you know, accurate, credible findings, a record of corrective action so that you can show good faith in dealing with the errors as they come. So Nate, thank you so much for joining me today
Thanks for having me
on Triage. And thank you everybody for listening. Hope you have a great day, and I hope this was a good resource for you.
Thanks again for listening to Triage, timely conversations for healthcare professionals. New episodes are available for download through Apple Podcasts, Google Podcasts, and Spotify. By subscribing to Triage, you will receive timely notifications for each new episode. Also, if you have any topics you would like to hear discussed on Triage, please don't hesitate to email triagesupport@klgates.com. We would love to hear from you.